Hello, I'm Shubham Kewalramani. I'm a third year MBBS student from MGM Medical College, Aurangabad.
So let us get started with the case discussion now. This was the case scenario given to me. A 40-year-old Caucasian man presented with a 1-week history of a rapidly progressive left-sided facial paralysis. The patient described a recent upper respiratory infection that began as a nasal congestion and drainage and progressed to a lower respiratory infection. Approximately four days after starting antibiotics, he noticed an acute onset of weakness on the left side of his face. He complained of difficulty with drooling, especially while drinking liquids, and irritation of the left eye. He also reported left-sided otalgia, oral fullness, and hyperacusis. On physical examination, the patient appeared to be a well-developed man in no acute distress. The facial nerve function on the left side was a House-Brackman grade 5 out of 6, with asymmetry at rest and incomplete closure of the left eye. As a hint, I was also provided with this picture of a person with a similar condition. Now I'll try my best to give an opinion over this case under the following headings. My approach to the case. So as we look at the presenting complaints of the patient, the first one being weakness of the facial muscles of left side or left-sided facial paralysis. Which nerve supplies the facial muscle? Yes, it's the facial nerve, the seventh nerve. So as the facial nerve is affected, there are many causes possible for its compression or lesion, like trauma, which can lead to transverse or longitudinal fractures of the temporal bone. Do you know which type of fracture is more common and which one causes facial nerve palsy more commonly? Some viral infections are known to cause facial nerve palsy like the herpes simplex virus, herpes zoster virus, Epstein-Barr virus. Causes can also be iatrogenic during mastoid or parotid surgery. Tumors from nearby zones can also cause compression of the nerve. Now as we notice, the paralysis of the complete left side of the face was there, the onset being sudden and it was progressed rapidly. This tells us that it's a lower motor neuron lesion of the facial nerve as both upper and lower halves of the facial muscles are involved. In upper motor neuron lesions, only the lower half of the opposite side of the face gets paralyzed, as the upper halves have dual nerve supply. Other presenting features of the patient were drooling, left eye irritation, hyperacusis, and left-sided otalgia with oral fullness. The patient had also given a recent history of respiratory tract infection for which he took antibiotics. Signs of facial asymmetry at rest and incomplete closure of left eye were also noted. On further physical examination, he appeared well with no other distress or complications. His House-Brackman scale score was a 5 out of 6, which denotes there was a severe paralysis of the facial muscles. I would further suggest for blood tests such as total count, peripheral smear, blood sugar, and also serological tests to be done. An imaging test like X-ray and CT scan of the temporal bone. So up till now, I think it's a low motor neuron lesion of the facial nerve. And according to the study of the findings, my differential diagnoses are Bell's palsy, Melkersson syndrome, herpes zoster oticus, malignant otitis externa, Lyme disease, Guillain-Barré syndrome, vestibular schwannoma, and meningioma. Now we'll see all the conditions one by one and try to rule out them to find out the most probable diagnosis. Bell's palsy. It is the most common idiopathic facial nerve paralysis, and I'll discuss this further later in the video. Melkersson syndrome. This one is also an idiopathic disorder, and it typically consists of a triad of facial paralysis, swelling of lips, fissured tongue. As the complete triad is not observed, we can rule out this condition. Herpes zoster oticus. Do you know what is the other name for this condition? You're right if you're thinking it's the Ramsay-Hunt syndrome. In this, the patient presents with vesicular rash in the external auditory canal and pinna, along with facial paralysis. There is impairment of 8th nerve as well, and patient complains of giddiness and hearing impairment, which our patient has not presented with. Next comes malignant or necrotizing otitis media. This is an infectious cause of facial paralysis which is seen mostly in diabetic individuals almost 90% of the cases suffer from diabetes. Then Lyme disease, also known as Lyme borreliosis. It is an infectious disease caused by Borrelia bacterium. Do you know it is spread by which parasite? Please write it in the comments. The most common sign of this disease is an expanding red rash which has a bullseye appearance, which is known as, yes, erythema migrans. We can easily rule out this condition then. Guillain-Barré syndrome. This is a rare autoimmune neurological syndrome which most usually involves bilateral facial paralysis. Unilateral facial paralysis, as seen in our case, is very unlikely. Then comes vestibular schwannoma, also known as acoustic neuroma, a tumor which arises from the 8th nerve. It presents with sensory neural hearing loss, which is unilateral, and tinnitus. Sensory fibers of facial nerve are also affected early in the presence of this tumor, but motor fibers are resistant to it. Therefore, this condition can also be ruled out. And last, meningioma. This one also presents with diplopia, headache, tinnitus, along with facial paralysis. Since all these symptoms are not present in our case, this condition is not likely to be our answer. So the most probable diagnosis from the given scenario and the discussion according to me is Bell's palsy. It is an idiopathic peripheral facial nerve disorder which is sudden in onset, and patient is unable to close the eye and on attempting the eyeball turns up and out, which is the Bell palsy phenomenon, as you can see in the video, and accompanied by features like dribbling of saliva from the angle of mouth, asymmetry of face, otalgia, hyperacusis, which were all seen in our patient. Conditions seen more often in this condition is more often seen in pregnant ladies, diabetic patients, and upper respiratory tract infection patients, as was seen in our case. Further, it is a temporary disorder, but its recurrence is possible. Now we come to the management of this case. So, general management involves reassurance of the patient. Analgesics should be given for earache. Proper care of the eye should be taken as the patient is unable to close eye of the affected side. So it can cause drying of the eye, which can further cause exposure keratitis or corneal ulcer. Physiotherapy or massage of the facial muscles is given for psychological support of the patient. Medical treatment. It includes steroids, the drug of choice being prednisolone. Adult dose 1 milligram per kg per day, dividing into morning and evening doses for 5 days. Dose should be tapered for the next 5 days if there is improvement in the patient and the paralysis is recovering. If there is no recovery or improvement, the dose should be continued for the next 10 days and then tapered for the next 5 days. So in total 20 days. Contraindications of steroids are diabetes, pregnancy, hypertension, peptic ulcer, glaucoma. Steroids are also useful in preventing synkinesis, crocodile tears. What is this condition also known as? Yes, gustatory lacrimation, and to shorten the recovery of the patient from this condition. After that, antiviral drugs are also given, like acyclovir is combined with steroids for treatment of Bell's palsy and herpes zoster virus. The surgical treatment is nerve decompression, which relieves pressure on the nerve fibers and then improves the microcirculation of the nerve. Vertical and tympanic segments of the facial nerve are decompressed by this. Total decompression, including labyrinthine segment by the post-oral or the middle fossa approach, can also be done when suggested. So that was my solution to the case. Hope you all like my discussion. Thank you.